I think it couldn't have been better than this, to watch you people, to hear you people from our comfort zones. So Dr. John is an alumnus of the prestigious Manipal College of Dental Sciences, and
Hello?
so
Ma'am,
there
we
is
can't hear you.
going wrong.
Ma'am, we can't.
Pragati, I'm unmuted here.
Yes, ma'am, you are unmuted, ma'am. Please continue, ma'am.
I'm sorry for the mess here, but bye.
Ma'am, we can hear you. You just continue, ma'am.
Okay. Sorry for the mess.
Please go ahead.
Why is everything getting repeated? I don't understand.
Ma'am, it's not repeated. We can hear you. And it's not getting repeated.
Okay, Dr. George, he has also been the fellow, Academy of General Education, Manipal, a thorough academician. He is the reviewer for Journal of Indian Prosthodontic Society and Journal of Interdisciplinary Dentistry. He is an advisory board member of Kerala Dental Journal, Indian Dental Association, Kerala State Branch, and clinician par excellence. He is a consultant to many tertiary dental clinics in Kochi, Kerala. Dr. George John, it's my pleasure to welcome you on this virtual platform here, sir. A warm welcome from us.
Thank you so much. Thank you so much.
Person for this session is a young, dynamic, and charismatic lady, our scientific chairman, Dr. Pragati Kaurani. She had been in Mahatma Gandhi Dental College and Hospital ever since she finished her post-graduation from Bharatiya Vidyapeeth, Pune in 2006. An ardent researcher, she is pursuing PhD in prosthodontics. She has done several distance learning programs, both at national and international levels, in research. She has also authored many books on research methodology. She has conducted several lectures and workshops in research methodology and also ran an FB page on research with more than 500 followers. She has secured 2 grants for her research projects, which is a huge achievement. Apart from research, she is a reviewer in the Journal of Indian Prosthodontic Society and the International Journal of Dental Sciences and the associate editor at the Enviro Dental Journal. Dr. Pragati has also several presentations at IPS national levels. Dr. Pragati, it's a pleasure to know you, and I welcome you to chair this session.
Thank you, ma'am. Thank you so much. Dr. George, could you please introduce the keynote speaker, sir?
Thank you so much, Dr. Shashikala. I hope I'm audible.
Yes, sir.
A warm good afternoon to all the delegates to virtually yet another first by the Indian Prosthodontic Society when it comes to postgraduate conventions. And it is an extreme honor for me to be here this afternoon, having by my side, as you rightly said, Dr. Shashikala, a young, dynamic, and evergreen chairperson in Dr. Pragati and the scientific chairman of this convention. It is our proud privilege to have this afternoon a podium lecture on the Indian Board of Prosthodontics by one of its young diplomates, Dr. Murtuza, who will be speaking on the excellence in prosthodontics, which in essence defines why we have the Indian Board of Prosthodontics. And I consider it my privilege to now introduce our respected keynote speaker, for this afternoon, Dr. Murtuza. Dr. Murtuza completed his undergraduation from the prestigious Government Dental College and Hospital in Mumbai, and then went on to do his master's in prosthodontics from the Ravara Institute of Medical Sciences at Loni. He subsequently served as a faculty at the M.A. Rangunwala College of Dental Sciences, Pune, and incorporated much of his academic activity with his private practice as a consultant. He's also pursued a fellowship from the International Congress of Oral Implantologists and is one of the diplomates of the Indian Board of Prosthodontics. He subsequently has migrated to the United Kingdom in 2019 after clearing the overseas registration examination and is working there as an associate dentist with the intention of taking his career forward in the United Kingdom. He is constantly updated by attending various courses on continuous professional development, has been a national and international speaker, as well as has several publications at both national and international levels to his credit. It is an honor to have you here with us from the UK, Dr. Murtuza. We welcome you on behalf of the organizing committee to refine our knowledge and take us towards excellence in prosthodontics. Over to you, Dr. Murtuza.
Thank you, Doctor, for the kind introduction. Good morning, friends and colleagues. I am Dr. Murtuza, and I am speaking on behalf of the Indian Board of Prosthodontics today. I am thankful to the Indian Prosthodontic Society and the organizers of this PG convention who have given me this opportunity to speak at this podium today. When you do your post-graduation, you develop your skills. You set goals for yourself and set up a system and start your practice. Then you start marketing your skills and grow your practice. And the word of mouth is the best publicity you can have, where your patients and colleagues refer you patients, and this helps you grow further. But once you reach higher, you don't have to let the momentum slip away. You build up a reputation so that people swear by your work. Then you build up a resume that you show off to the world, and thus build up a Rolodex, that is the contacts in your professional field. So whenever there is a challenging case, your colleagues directly think about you and refer that case to you. That's exactly the reason why the Indian Prosthodontic Society has started the Diplomate of the Indian Board of Prosthodontics. It is the Indian Prosthodontic Society's avenue for identifying, recognizing, and certifying exceptional performance and excellence in all aspects of prosthodontics. So what is the Indian Board of Prosthodontists? It is a premier board of prosthodontists formed by the Indian Prosthodontic Society, the purpose of which is to identify the cream with exemplary skills and knowledge. This is through a series of qualifying examinations. The board certifies the successful candidates who meet all the requirements as the diplomats of the Indian Board of Prosthodontists. The goal of the board is to ensure that the diplomats meet a high degree of knowledge and skill, and once they have achieved this, issue certificates to them. It also ensures that diplomats maintain continued proficiency in the science of prosthodontics and its allied subjects. It also lets the public and the profession know who the board certified members are, and thus encouraging the specialty to enhance further. Now you all would be wondering, how can I become board certified? The certification process is fairly simple. It consists of two parts. The first part is theoretical and consists of multiple choice questions. The second part consists of case presentations. Now let us see what is the eligibility criteria to become a member of the Indian Board of Prosthodontics. All the members of the Indian Prosthodontic Society possess an MDS degree are eligible to apply for this. In fact, even student members who have cleared their first MDS, that is second year onwards, can appear for the Part 1 examination. The registration process is fairly simple and the fees is nominal. Who should apply to become a board member? I would say any prosthodontist or a student of prosthodontics who thinks that he or she wants to achieve some higher qualification, somebody who wants to stand out among the specialists, and someone who has a hunger for knowledge and wants to check if they are on top of their specialty. Now let us see how you can apply. The process is fairly simple. You just need to log in to the IPS portal, fill up the selected form. The examination is held twice a year, so you need to choose which examination you want to give. Complete the payment process. You will receive a confirmation and also a hall ticket 10 days prior to the examination. Part 1 examination is a written examination which consists of 200 multiple choice questions. It is held usually twice a year during the national conference and the PG convention. However, due to current circumstances and COVID-19, this is going to be held online. This year, the exam is scheduled for 25th of July and the 28th of November. The results of the Part 1 examination are announced within few days, and the candidates who have cleared are awarded with certificates during the conference. You are eligible to take the Part 2 examination 2 years after passing the Part 1 exam. Those students who have cleared the Part 1 examination during their post-graduation can take up the Part 2 exam 2 years after they have cleared their masters. Once you have collected and built up your cases, you can apply for the Part 2 exam. Again, the application is online and the process is fairly simple. The fees is quite nominal. You need to submit your cases in the requisite format few weeks before the exam. This year, the Part 2 assessment is scheduled for November. Usually it is held before an IPS conference. The exam is in a quiet and informal setting and consists of case presentations and orals. There are various cases required from removal prosthodontics, fixed prosthodontics, maxillofacial prosthodontics, TMJ disorders, and implantology. The various cases that are required are displayed on the IBP website. The most encouraging thing about this exam is that there is no pass or fail. It's either complete or incomplete. At the culmination of the effort and hard work, you will reap the fruit. A prestigious graduation ceremony will get you admitted to this elite club of accomplished individuals. Success has many forms. Once you establish a practice, you may think that you have done it all. But outside of this neighborhood, there is greater success. You can earn national and international recognition, create a brand of your own. Being a nationally certified practitioner gives you global recognition, and you are held in high esteem the world over. The diplomats of the Indian Board of Prosthodontists are Dr. Anand Krishna and Dr. Mohit Khaur, who completed the exam in 2016, Dr. Anita Gala Doshi, and myself, who completed the examination in 2018, Dr. Sendil Nathan, who completed in 2019, and Dr. S. Sabrinathan, who completed in 2020. You may think, why do I need to take a board certification? To differentiate yourself from other specialists of the same genre? To keep up to date on the subject? To have an assessment of your own skills and knowledge? I think this was the one that motivated me the most. Possibly, examination and stress brings out the best in you. You may think, once you're a senior clinician, how can you improve? This is an opportunity for self-assessment and improvement. You would like to take this challenge up like that only, to increase your knowledge, to improve your skills, to respond to competition, and the most important, I think, set the goal and set up to a challenge. You might have some common refrains, like, I don't have time. But my friends, time needs to be created if you want to do something big in life. Is it of any value? Believe me, this will keep you ahead of the competition. My patients cannot afford, or I don't have patience to go in for this kind of treatment. Friends, the cases which are required are the basic cases that are expected in your post-graduation. You might feel it is too complicated for my practice, but you just need some time to record the cases well. Or you might think, what if I fail? As I mentioned earlier, there is no fail or pass. It's either complete or incomplete. The certification from the board will give you an identity, and identity is destiny. You have to be distinct or be extinct. Why should you take a board certification? The examination will show you your weaknesses and the scope for improvement. It will allow you to be examined by your peers. It will show you the quality of work and your record keeping. It will critically tell you about your diagnosis and treatment approaches. Your treatment protocols will be at the highest level. In case you are looking for a job abroad or in India or looking for a promotion, this will be an additional achievement under your belt. What are the opportunities once you become board certified? You can make your presentations on the IBB podium like I am doing today in front of yourself. You will be well known amongst your peers and be recognized as a premier prosthodontist. You can exhibit the diplomate against your name, and you can progress to become the director or the chairman of the board in the near future. Let us see a few cases now. Rehabilitation of a completely edentulous maxilla and partially edentulous mandible with implant-supported screw-retained fixed prosthesis. A 72-year-old female patient reported with pain in her lower front teeth. The pain was sharp and experienced on biting. There was sensitivity on eating cold. She was unable to eat or speak well and was embarrassed to socialize due to the unacceptable aesthetics. She had discomfort with her dentures and experienced a gag with them. Past dental history revealed long spine bridges in both maxillary and mandibular jaws which failed, after which a maxillary complete denture and a mandibular partial denture was fabricated. The medical and social history was non-contributory. Extraoral examination revealed a medium smile line and reduced facial height due to loss of teeth. Intraoral examination revealed a thin mucosa with areas of redness seen in the denture-bearing area. the salivary flow was reduced. There were no teeth in the upper jaw and just 7 in the lower jaw. There was a cantilever bridge on the lower right 6 with support from the lower premolars. There was a crown on the mandibular left canine. There was decay with the mandibular right canine. The mandibular left and the right canines were tender to percussion, and there was no mobility with any teeth. The IOPA of the left canine showed a root canal treated tooth with no evidence of root fracture and no periapical changes. The IOPA of the right canine showed a distal radiolucency in close proximity to pulp, but there were no periapical changes. Since the patient was interested in dental implants, a cone beam CT was done with duplicated maxillary denture used as radiographic stent to evaluate bone for implant placement. The CBCT showed root fracture in left mandibular canine. Thus, the diagnosis was a root fracture with left mandibular canine, apical periodontitis with right mandibular canine, a completely edentulous maxillary alveolar ridge, and a partially edentulous mandibular jaw. Phases: immediate phase, stabilization phase, definitive phase, and maintenance phase. In the immediate phase, since the patient was unwilling for root canal with the right mandibular canine, we had to extract that. The other canine also had to be extracted since it had fracture. In the stabilization phase, we gave oral hygiene instructions, we did scaling and polishing, we removed the bridge involving the premolars and the molar, and thus replaced with a temporary acrylic crowns. We also made a new maxillary complete and a mandibular partial denture. This helped us as a diagnostic tooth setup. We also could assess whether a fixed or removal prosthesis was indicated, and it could be converted into a definitive prosthesis should removal appliances be chosen. Based on the information gathered from diagnostic denture and CBCT, 7 implants were planned to be placed in the maxillary jaw, and a screw-retained prosthesis was planned. 5 implants were planned in strategic locations in the mandibular jaw so as to allow replacement of future teeth if they are lost, and a screw-retained prosthesis was planned. The maintenance phase included reviewing the prosthesis for quality and hygiene, reviewing the implant fixtures and their health, and the long-term supportive periodontal therapy and periodontal maintenance of implants. This is the pre-surgical intraoral view of the maxillary and mandibular jaws. As per the CBCT data, 7 implants were planned in the maxillary jaw. They were in 1-6, 1-5, 1-4, 1-2, 2-3, 2-5, and 2-6 region. The duplicated denture was used as a surgical stent, and the implant positions were marked. Separate flaps were raised on the left and the right side, and the implant placement was done. Parallelism was checked using paralleling pins. After implant placement, the flaps were sutured. This is the OPG after the maxillary implant placement. Due to financial constraints, the patient did not want to go for mandibular implants immediately. This was a freehand surgery, and you can see the parallelism amongst the maxillary implants. Healing after 3 months. After 3 months, a second stage surgery was performed and gingival formers were placed. An interim screw-retained bridge was fabricated for the patient. The interim maxillary bridge opposing the treatment partial denture in the frontal view. The interim maxillary bridge opposing the treatment partial denture in the right lateral, the left lateral, and the occlusal view. The extraoral view of the patient. After a couple of months, implants were planned in the mandibular jaw. Implants were planned in the 4-6, 4-3, 3-3, 3-4, and the 3-6 region. A guided surgery was planned in the mandibular jaw. As per the bone availability, the implant diameter and length were determined. A tooth-supported surgical stent was fabricated for the fully guided surgery, and this is the intraoral adaptation of the stent. The implants were placed in the desired location using the guided stent. This is the OPG after the lower implants were placed. 3 months after the implant placement, second stage surgery was performed and healing abutments were placed. Once the soft tissue around the healing abutment had healed, open tray impression posts were attached. The fit was verified by taking X-rays, and then they were splinted using pattern resin. Final impression was made using monophase polyether in a stock plastic tray. The cast was then poured. A jig trial was then made on the cast, and then it was verified in the mouth. Similarly, open tray impression posts were placed on the mandibular implants. The fit verified using X-rays. Impression was again made in monophase polyether in a stock plastic tray. A jig trial was done for the implants after that. A phase bow record was then made using the Hanau spring bow, and the cast was then mounted on the Hanau modular articulator. The metal trial in the patient's mouth. The BIS trial in the patient's mouth. The occlusion was adjusted and refined. And this is the intraoral view of the final restoration. In maximum intercuspation, there were even contacts on all posterior implants, and there was no contact on the anterior implant. In lateral excursion, there was group function on the posterior implants, no contact on the balancing side, and shallow lateral guidance. In protrusion, there was guidance on anterior implants, and the guidance was kept as shallow as possible. The post-treatment right lateral and left lateral view. The post-treatment occlusal view. This is the post-treatment OPG. The post-treatment extraoral view. These are the intraoral pictures at the 18 months follow-up. And the IOPs taken at the 18 months follow-up period. Let's look at the second case now. Rehabilitation of wound dentition using porcelain fused to metal crowns and bridges. A 65-year-old female patient complained of sensitivity in teeth. The sensitivity was increasing since the past 3 to 4 years and is of concern now. Eating was impaired due to loss of teeth in the lower right side. The medical history revealed history of gastroesophageal reflux disease and frequent bouts of vomiting. Otherwise, the patient was fit and well. The past dental history revealed a 3-unit bridge in the mandibular jaw on the right side which failed after one of the abutment teeth had to be extracted. The social history revealed a stressful lifestyle and history of bruxism. Extraoral examination revealed an opening click on the TMJ on the right side, and there was slightly reduced facial height due to adhesion of teeth. The pre-treatment intraoral presentation. The maxillary and mandibular occlusal view. The right lateral and the left lateral view with teeth in occlusion. The intraoral examination revealed a fair oral hygiene. there was some bleeding on probing. Most of the teeth were present except the upper left 6 and the lower right 5 and 6. There was a bridge replacing the upper left 6 from 5 to 7. And there was a retained root with lower left 8. The OPG revealed good bone levels, an extraction socket with lower right 5, a retained root with lower left 8, and slight bone loss with lower right 1. The treatment plan included a diagnostic mounting on the semi-adjustable articulator, raising the vertical dimension of occlusion by 1.5 mm and proceeding with the diagnostic wax-up, scaling and root planing, extraction of the lower left 8, crown lengthening of the lower right 7. The tooth preparation and temporization of all teeth was done as per the diagnostic wax-up, using Pro-Tempo as a material and a direct method of temporization. The temporary phase was for 2 months. Individual PFM crowns were fabricated for most of the teeth. PFM bridges were planned to replace the upper left 6 and the lower right 5 and 6. The crowns and bridges were planned in 2 phases, anterior and posterior, so as to maintain the vertical dimension of occlusion determined during the temporization phase. At the end of treatment, a soft night guard was fabricated. The diagnostic, maxillary and mandibular casts. The phasebow transfer was done using the Hanau springbow. Bite was recorded using AluVax and an anterior deprogramming device. The Broderick's flag was used to determine the mandibular posterior occlusal plane. With the help of all this information, a diagnostic wax-up was done on the Hanau articulator. The diagnostic wax-up was then shown to the patient. Once the patient approved the diagnostic wax-up and gave consent, we went ahead with the preparation of teeth. Temporaries were then fabricated using Pro-Temp and putty indices made from the diagnostic wax-up. You can note an instant change in the patient's smile. Of course, the temporization period gives both us and the patient a chance to evaluate the teeth and give suggestions for the final definitive restoration. The occlusion was adjusted carefully and canine guidance was kept on both sides. Once both the patient and myself were happy with the temporaries, upper and lower alginate impressions were made of the teeth. Casts were then poured and mounted on semi-adjustable articulator, and a custom incisal guide table fabricated using acrylic resin. The temporaries were kept in the mouth for 2 months. Once the patient got used to the new vertical and the new bite and was comfortable, she agreed to proceed with the final restoration. The anterior temporaries were then removed and the teeth prepared. The posterior temporaries were kept in place as this would maintain the new vertical and the centric that was established earlier. Impressions of the prepared anterior teeth were then made using putty and light body using a 2-step impression procedure. The casts were then again mounted on the semi-adjustable articulator and the lab procedure was carried out. Intraoral picture of the cemented anterior crowns. My apologies for the poor quality of the picture. Once the anterior crowns were finalized, we proceeded with the posterior restoration. The teeth were prepared and final impressions were made using putty and light body using a 2-step impression procedure. Now the main advantage of separating the anterior and the posterior preparation is that we can maintain the vertical and the centric that was achieved during the temporization period. The cast mounted on the semi-adjustable articulator. The intraoral picture of the cemented PFM crowns. And an extraoral post-treatment presentation. and the intraoral post-treatment presentation of the maxillary and mandibular teeth. The right lateral and the left lateral views of the teeth in occlusion. A canine-guided occlusion was established and maintained as was in the temporaries earlier. The pre-treatment and the post-treatment presentation. Let's see another case. A tooth-supported maxillary and mandibular overdenture. It is a very regular and a simple case that most of us do during our post-graduation. But the important thing here is how it is planned so that we achieve a good aesthetic result. A 67-year-old male patient with partially edentulous maxillary and mandibular arches complained of inability to eat due to missing teeth. He had lost several teeth due to caries over the last 3 years and desired replacement for the same. The patient was fit and well and gave no significantly relevant medical history. Past dental history revealed loss of teeth due to caries. Social history was non-contributory. Extraoral examination revealed reduced facial height due to loss of teeth. Intraoral examination revealed firm and resilient mucosa and slightly reduced salivary flow. Only 2 teeth were present in the upper jaw, that is the 2 central incisors. In the lower jaw, there were only 3 teeth present, lower left canine and first premolar, and lower right canine. Root canal treatment was already done for the upper central incisors and the lower left premolar. So the diagnosis was partially edentulous maxillary and mandibular arches, Kennedy's classification class 1 in the maxilla and class 1 modification 2 in the mandible. The treatment plan involved giving dome-shaped copings for the upper central incisors. The patient was insistent on not getting them extracted and wanted to preserve them. Dome-shaped copings were planned so that they don't interfere with aesthetics. Short coping was planned for the lower premolar. Ball attachments Ryan 83 were planned for the lower canines, and a tooth-supported maxillary and mandibular overdenture was planned. This was a pre-treatment intraoral presentation. You can see the upper central incisors, almost root stumps. They were root treated. The lower right canine and the lower left canine and the second premolar. Diagnostic impressions were made using alginate in stock trays. Root canal treatment was done for the mandibular canines. The bite was recorded and a trial setup done. The trial was done so as to evaluate the entire planning for the Ryan 83 attachment. Now, using a trial as a reference, the teeth were prepared to the desired height to receive the copings. The attachment space was then evaluated using this trial. Now, this step is very critical and important in the entire aesthetics of the denture. If this is not planned well, then what happens is the vertical dimension can be raised or the lower occlusal plane goes above the corner of the mouth, and this impairs the aesthetics. Final impressions of the copings were then made using putty and light body. The wax pattern was then fabricated on the cast. A Ryan 83 attachment was planned on both the lower canines, and simple copings were made on the lower premolar. Dome-shaped copings were planned for the upper central incisors. The dome-shaped copings cemented on the upper central incisors. The short coping cemented on the lower premolar, and the Rhine 83 attachment cemented on the lower canines. Trying was again done at this stage to check the availability of space for the Rhine 83 attachment. Once we were happy with the trial and sure that the occlusal plane would not go above the corner of the mouth, we went ahead with the final impressions for the upper and lower residual alveolar ridges. A phasebow record was then made using the Hanau spring bow and then transferred to the semi-adjustable articulator. Now a final trial is done before we can proceed with the final definitive prosthesis. Now, if you have noticed, I have given a lot of emphasis to keep on checking and trying it again and again. The main reason being that in overdentures, because we are trying to preserve teeth and add an attachment, the level of occlusal plane can go above the corner of the mouth, and this impairs the aesthetics of the denture. The right and the left lateral view. Now at this stage, a protrusive interocclusal record was taken so as to program the articulator. The teeth arrangement was then slightly modified so as to achieve a bilaterally balanced occlusion. The final prosthesis in the mouth. The right and the left lateral views of the dentures in occlusion. And the extraoral view of the patient with dentures in his mouth. The maxillary complete denture and the attachments seen in the mandibular overdenture. The pre-treatment and the post-treatment extraoral view of the patient. You can very well appreciate that the lower mandibular occlusal plane is just maintained at the corner of the mouth. Now, if you see the cases that I have presented, these are the cases that most of us do in our post-graduation or during a regular clinical practice. The important thing here is to do it meticulously and record them well so that we get a good final result. Giving importance to the finer details is very important to achieve this precise result. Far too often, we are presented with opportunities, but we are hesitant to take a step because we are afraid to step out of our comfort zone. No one remembers the day they lived in status quo, but everyone remembers the days we got up and did something different, which made a significant change. Let me invite you to change your future and your practice with the Indian Board of Prosthodontics. So my friends, the Diplomat Club is awaiting you. Log on to the IPS portal and register for the Part 1 exam. As someone has rightly said, nothing is impossible. Only you have the power to sculpt yourself into what you can become. Thank you.
Thank you, sir, for such a wonderful lecture. I must compliment on the beautiful photographs and the way these concepts were so clearly explained. Thank you, sir, for such a fantastic lecture.
I thank Dr. George and I thank Dr. Pragati for making it Dr. Pragati, you need a special thank for organizing it so well and for inviting such good people to hear too. Dr. Murtuza was excellent.
Yes. Excellent.
And
yes, ma'am.
Thank you very much.
He has emphasized on one point which I appreciate, that be meticulous, keep checking, repeated verification, keep emphasis on jaw relations, which most of the postgraduates don't follow.
Yes, ma'am.
This is one thing, how meticulous we are when you're delivering your services before you expect the patient to cooperate with you. I thank you, Dr. Murtuza, so much for emphasizing on these points. And
Thank you,
Dr.
ma'am.
George, we'll miss your lecture, but you've been here with us. And thank you so much for being here with us. And as an appreciation, we give you this e-certificate on behalf of the organizing committee. Thank you.
Thank you, Dr. George. Thank you so much. I would also want to thank you, though Madam was saying I just intervened in the middle, but thank you, sir, so much.
Thank you so much for this opportunity, and certainly graciously accept your appreciation very sincerely. Dr. Murtuza, you certainly have inspired, I'm sure, many to take up the challenge which they perceive in appearing for an IBP examination. Your lecture was not only insightful, it was equally nostalgic. I remember attending the graduation ceremony of the first diplomates in Navi Mumbai, and then your graduation at Mangalore. Certainly, you also helped us to realize that how much more it's important to address your patients in a very, very disciplined manner that would ensure that documentation is kept in mind to the extent that you want to improve yourself. And certainly, that is the path to excellence that I think your lecture defined. Sincerely grateful for the time that you've spent with us. And it is such an honor to have been with you once again this afternoon.
Thank you, sir. It was an honor for me too.
Thank you, sir. Thank you.
Stay safe, and God bless you. Thank you for joining.